So good evening, everyone. Should we start? Please give the thumbs up if audio and video is clear. Good evening, everyone. Please give a thumbs up if audio and video is clear. Okay, so here we start the class. The topic of today is, first we will be doing the genital fistula and then we will be covering the oncology. Okay, so okay Isra, okay Shilpa, hello Rahul. So here we start the class. Okay, so first of all, I would like to tell you what is fistula. What is fistula? Do write in the comment section what is fistula. Fistula is something you can say a connection between the two tracts, right? I'm getting my pen. Okay. What is fistula? Fistula is a connection between the two tracts. Okay. Sorry for interruption. Here we started. Daily the class will start at 4:30. Okay. Okay. Somewhat time like this, 4:25 to 4:30. Is it okay? 4 o'clock it is not manageable for me. So we will start the class. Yeah, I will give the PDF just after the class. Okay, PDF is ready. Yeah. So fistula is a communication between the two tracts. Okay, because we are studying the fistula of the genital tract, so here we will be talking about mainly the genital tract. Okay, all the fistulas which come in our exam are the urogenital tract communication. Okay, so now here you can see that mainly in the genital tract we have uterus and vagina, right? And all the fistulas which are in our syllabus are connected to vagina. Okay, so we need to see that the fistulas, a communication between the vagina and the urinary tract is in our syllabus. Okay. Okay, Shilpa, focus here. It will be given. Don't worry. Okay, it will be given. So, what is fistula? Which all fistulas are in our course? They are between the communication of the vagina and the urinary tract. Okay, and this is the urinary tract. So, with what the vagina is communicating with the urinary tract, with what all is the vagina communicating. So vagina is communicating with ureter, vagina is communicating with bladder, vagina is communicating with urethra. Okay, so this is vagina, and now here the vagina is, if fistula happens here, then here the vagina is communicating with the ureter. So this fistula will be known as, write down in the chat box, be fast, uretrovaginal fistula. Okay, and if the communication is here, the second one, this one will be known as vesicovaginal fistula. Okay, vesicovaginal fistula. The third one, the communication between the urethra and the vagina is known as urethrovaginal fistula. So basically we have these three fistulas in our syllabus. Okay, the communication between the urinary tract and the vagina. So if the upper communication is known as uretrovaginal fistula. The lower communication just below it is vesicovaginal fistula. And the third communication is the urethrovaginal fistula. Is it clear to all of you? Okay. Now this is, as you all know, posteriorly lies the rectum, right? If the posterior communication link, you should also know the fourth fistula is rectovaginal fistula. Okay? Okay, please keep on interacting in the chat box so that I know that you all are awake. Okay? So, the uretrovaginal fistula is the most upper one. The middle one is the vesicovaginal fistula, and the lower one is the uretrovaginal fistula, and the posterior one is the number 4 here. This one is the rectovaginal fistula. Is it clear to you? Terms are clear? In FMG 22, the question was asked on vesicovaginal fistula. Okay, Rahul. Okay. Now we will discuss that what is the patient, what history patient gives. Now, as you have seen that the mainly the urinary tract is communication with the vagina is in our syllabus. So if the urinary tract will communicate with the vagina, then what complaint will the patient give? The patient will give what complaint? Write down in the chat box. What complaint the patient will give? If there is a urinary tract and genital tract communication fistula, what complaint the patient will give? Urine coming out of the vagina, isn't it? So patient will say that urine is coming out of vagina. So whenever a complaint in exam is there that urine is coming out of vagina, will you write there incontinence? No, incontinence is not urine coming out of vagina. This is a fistula. Okay, this is a fistula. And if this fistula is this rectovaginal, then what will be the complaint? If the fistula is rectovaginal, the fourth fistula, then what will be the complaint? Write down in the chat box what will be the complaint if fistula is rectovaginal. Stools or flatus will come out, right? If the fistula is rectovaginal, then stools or flatus will come out of vagina. Okay. Now let us see how the uretrovaginal, vesicovaginal and uretrovaginal fistula complaint varies. Okay. When the fistula is in the ureter, this upper one, fistula, okay, then the patient say, I have a good control over my maturation, but the urine dribbling is there, but it is very, very less. Dribbling of urine is there, but it is very, very less. Okay. So what is the complaint of the patient? Patient says that bladder sphincter control is good. That my sphincter control, my bladder control is good, but urine dribbles sometimes. Okay, because you all know that bladder control, sphincter control is with external urethral meatus. See, here lies the external urethral meatus. This is the external urethral meatus. So bladder control is hampered in vesico-vaginal fistula. Otherwise, it is not hampered. Okay? Are you getting my point? So whenever there are ureterovaginal fistula, then whenever there is ureterovaginal fistula, there the the bladder control, ureter or vagina fistula is there, then the sphincter control is good, but dribbling is there, and that is also very minute. In the case of vesico-vaginal fistula, in the case of vesico-vaginal fistula, there is continuous dribbling. As you all know, bladder is a storage of urine. Bladder is full of urine. That's why. Okay. If it is a case of urethrovaginal fistula, this third one, the lower one, then in this case the patient complains of only during the micturition. As you know that the urine comes in the urethra only during the micturition. So only during the micturition the urine comes out of the vagina. So this is how, on the basis of history, you will differentiate these three fistulas. Okay. Now let us study the 3 swab test. Okay. Now what we do in the 3 swab test, we put 3 swabs in the vagina. As you are seeing that I have put the 3 cotton swab, one after the another. Okay. One after the another, we put 3 cotton swabs in the vagina, and we fill the bladder with the dye. Okay. Now what will be if upper swab is wet? If the most upper swab is wet but not stained, because why? Here we have not put the dye, or we have not filled the ureter. We have only filled the bladder with the dye. Okay. We have only filled the bladder with the dye. So if there is a ureterovaginal fistula, then the upper swab will get wet, but it will not get stained. So if in the question it is written that the upper swab has got wet but not stained, where is the fistula? Then the answer is ureterovaginal fistula. Ureterovaginal fistula. In the case of vesico-vaginal fistula, which is most commonly asked, the middle swab. The middle swab, it gets stained. Now, if there is a communication between the vesicle and the vagina, then this middle swab will get colored. As I put red dye, so the middle swab will become red and wet, both. And if there is a fistula in the urethra, so the lower swab will become red. Are you able to get it? The 3 swab test is the first test. 3 swab test is the first test. The best test is cystoscopy. This is very, very important. The best test to diagnose fistulas is cystoscopy. Okay. Best test to diagnose fistula is cystoscopy, to see the fistula. Okay. Now let us discuss about the ureterovaginal fistula and vesico-vaginal fistula and their causes. The ureterovaginal fistula, the most common, it is caused during the hysterectomy. Okay, because as you can see here in this diagram, the ureter is in communication with the ureter is in communication in front of the uterus. The ureter is near the uterus. Water under the bridge, you know, right? At that time, we ligate the time we clamp the uterine artery, by mistake we ligate the ureter sometimes. Okay, by mistake we ligate the ureter sometimes. So ureter is only in the peritoneal cavity. So peritoneal procedures, especially the hysterectomy procedures, is at risk of ureter injury or ureterovaginal fistula. Okay, the vesicovaginal fistula. Another thing is vesicovaginal fistula. The most common cause of vesicovaginal fistula in the world is hysterectomy. Okay, the most common cause of vesicovaginal fistula in the world is hysterectomy. What happens basically in hysterectomy, as you all know, we have to remove the uterus. So we cannot remove the uterus the way I am removing it. Okay, we have to separate this bladder. So during separation of this bladder, sometimes this bladder gets injured. Sometimes during the separation of the bladder, this uh, before removing the uterus, we have to separate the bladder. When we separate the bladder, then we will remove the uterus. Okay, so during that separation, sometimes a fistula is made. So most common cause of vesicovaginal fistula in the world is hysterectomy. Okay, but the most common cause of vesicovaginal fistula in India is obstructed labor. Can you tell me why? Because in India, if we go back 5-6 years back, most commonly the dyes were conducting the delivery. Okay, the dyes were conducting the delivery. So they dyes don't know how to diagnose contracted labor. Okay, contracted pelvis. The eyes don't know. They haven't done MBBS, right? So they were not able to diagnose contracted pelvis. So the patient goes into the obstructed labor. And what happens in obstructed labor? There is a contracted pelvis. So this fetus gets stuck at the fully dilated stage. Fetus is not coming down, and then this fetus puts the pressure on the bladder. The occiput of the fetus puts the pressure on the bladder. The lower uterine segment keeps on thinning. Okay, and this continuous increased pressure causes the vesicovaginal fistula. I hope it is clear. So should we start with oncology? If you have any problem, please write down in the chat box, or we will start with oncology. If you have any problem with fistula left, any query, or should we start with oncology? Please reply in the chat box. Okay, Isra, it's clear. Okay, let's start with cancers. Okay, first of all, which is the most common cause of cancers in female? When such a question comes in your exam, whether they have written in India or not, it means it is in India. Are you able to see oncology PDF? Yes, now you are able to see. Okay. Now, the most common cancer of in females is the CA breast. Okay. The second most cancer in female in India. Whenever it is not written and you are sitting in Indian exam, it means that they are talking about India itself. Okay. So the second most common cancer in female is CA cervix. Okay, so the CA cervix becomes the most common genital cancer, right? The most common cause of postmenopausal bleeding and most common cause of postcoital bleeding. Straightway question is this. Last time it has come in FMG. The most common cause of postmenopausal bleeding. The most common cause of postmenopausal bleeding in India is, whether India is written or not, is CA cervix. Okay? Is CA cervix. For both postmenopausal bleeding and postcoital bleeding, both the most common cause is CA cervix. And the most common cause of postmenopausal bleeding in word is endometrial atrophy. Okay? The most common tumor. Please write the answer to this question. Don't see on the slide. Most common tumor in India or in whole world. What is it? Write down in the chat box. The most common tumor in females in the whole world is, the answer is fibroid or leiomyoma. So here we are asking the tumor. This was a question in December 20. The which of the following tumor has highest incidence? So the word tumor was there. Okay. No, Isra, it is not CA breast. Tumor. We are talking tumor. It is fibroid or leiomyoma. Already the question has been asked. It can come again. Please mark the word most common tumor. It can be benign, it can be malignant. Most common tumor is fibroid. Most common malignancy is CA breast. Most common benign tumor is fibroid. Okay? Have you got this concept? Please mark the answer for this. Causative agent of C cervix or CIN3. Please write down in the chat box the answer for that. The next question is, which of the following is caused by low risk type? HPV? Yes. HPV is of two types. High risk type, human papilloma virus, which cause CA cervix, is of two types. High risk type and low risk type. Okay. So you have to tell which of the following is caused by low risk type. This is NEET PG 22 question. Yes, Isra, you're right. It is HPV 18. Causative agent of CA cervix is HPV 18. So, low risk type mainly causes warts and laryngeal papillomatosis. The answer to this question is D. Okay, next question. The lady with warts was found to have a HPV of high risk type. Again, a PYQ. The lady with warts was found to have a HPV of high risk type. what is that HP type? Lady came to you with warts and it was found to have a high risk type HPV. Out of this, what is that HPV? Please reply in the chat box. What is that HPV? The HPV is HPV 18. Okay, so now let's discuss it. The HPV is virus. They are 100 type of HPV virus which cause CA cervix. All of you know HPV causes CA cervix. There are 100 serotypes of HPV which cause CA cervix. Broadly, they are divided into two types: low risk type and high risk type. Low risk type mainly contains two types, 6 and 11. Low risk type mainly contains two types, 6 and 11. These low risk type, they cause genital warts, and these genital warts are also known as condylioma acuminata. Okay, condylioma acuminata. And the other diseases which these low risk type causes: laryngeal papillomatosis. Okay, laryngeal papillomatosis. The high risk types contains, okay, Isra, belated happy birthday. High risk type contains a list of viruses, out of which we have to remember is 16, 18, 31, 33, 45, 52, 58. Okay, got it? High risk type contains 16, 18 and few more: 31, 33, 45, 52 and 58. Now these high risk type, they all cause cancers. Okay, they mainly cause cancers. Now you all know below cervix cancer is caused by high risk type. They also cause, below cervix is vagina. They also cause vaginal cancer. Below vagina is vulva. They also cause vulval cancer. Then posterior to the vulva is anus. They also cause anal cancer. Okay. Anteriorly there is penis. So penile cancer. Other than that, they cause oropharyngeal cancer. Okay, so high risk type, they cause oral cancers and genital cancer. Among the oral cancer, there is only one cancer, oropharyngeal. All the rest are the genital cancers. In the female, it causes cervix, vagina, vulva, anus. Okay, and in male, it causes anal and penile cancer. Okay, the most common HPV type which causes cancer is HPV 16. Okay, few days back I was asked by student that ma'am learn nahi hota 16. So you all know that at the sweet 16 age it's a one gets very easily famous, very easily get common. पूरा जोश होता है ना स्वीट 16 एज पे. एंड मोस्ट इन्वेजिव, मोस्ट स्पेसिफिक इज 18. सो 18 ईयर्स पे मैरिज हो जाती है तो हम बड़े स्पेसिफिक से हो जाते हैं, बहुत ही रिस्पॉन्सिबिलिटी उठा लेते हैं, इन्वेट कर जाते हैं, हम लड़की वालों के घर तक पहुंच जाते हैं. ठीक है, सो दैट इज द वे यू कैन रिमेंबर, अदरवाइज यू हैव टू क्रैम्प. ओके, now please listen carefully. already in November 22 question has come. Each line of this slide is very important. The genes which the HPV virus has are of two types: early genes and late genes. Early genes and late genes. Okay, early genes are denoted by E genes and late genes are written as L genes. Okay, among the all the early genes, E6, E7 is important. E6, E7, it is responsible for malignant transformation. Malignant transformation. जो HPV CS cervix करता है ना, for that transformation is possible due to the E6, E7 gene. And when we are making vaccine, then we target L1 gene. Okay, then we target L1 gene. L1, because that L1 gene codes capsid. That L1 gene, if this is the virus, this is the capsid. The outer proteins are the capsid protein. The L1 gene makes the capsid protein. When we make vaccine, we target on L1 gene, because if the adhesion is not the adhesion of the virus to the cervical cells, the cervix cell is the first step. The adhesion of the virus to the cervix cells is the first step. So we target on the first step when we make the vaccine. So this was a question which was there in the INI-SET exam. So these are very basic question. High chances are there. This question has repeated third time in the PYQ. So high chances are there that it will come to you. So there are basically two type of HPV virus, low risk type and high risk type. Low risk type, it causes warts, genital warts, also known as condylioma acuminata, and laryngeal papillomatosis, and it contains 6 and 11 type. The high risk type contains 16, 18. If you are the one जिनको बाद की याद नहीं होते, so I would like to tell you how to learn. After 16 and 18, you can learn it like this: 31, 33, 45. These, the second digit is the odd one. 1, 3, 5. Okay. Then comes 52, 58. The last two are the even. Okay. The last two are even digits, and the first three digits are the odd digits. Okay. Now this was a question which has come as per WHO. As per WHO SAGE guidelines, the recommended dose of HPV vaccine in 9 to 14-year girls is what dose? Okay. So let's study. The answer to this question is 1 or 2. We will study it now. Okay. There are 3 vaccines in the market for cancer cervix. As you all know, the etiology of cancer cervix is HPV virus, right? So there are 3 vaccines. The Cervavirix vaccine, it targets 16 and 18 HPV, because that are the main types. Okay, Cervavirix, the Cervavirix, yes, the answer is 1 or 2. There is for intermediate as well, ma'am. I didn't get you, Isra. Please type again. The Cervavirix vaccine targets only 2 types, 16 and 18, and it is known as bivalent vaccine. The Gardasil targets 4 types, 6, 11, 16 and 18, and it is known as quadrivalent vaccine. There is the another vaccine, Gardasil 9. Gardasil 9 targets its 6, 11, 16, 18. Then the rest also 31, 33. So I told you 31, 33, 35, oh sorry, 45, 52 and 58. And it is also known as nonavalent vaccine. Okay. Now, if the vaccination can be given from the age 9 to 45, vaccination can be given from age 9 to 45. Okay. Is it okay? Right? And if we are giving the vaccine at 9 to 14, then it is perfect age. The perfect age to give vaccine is 9 to 14. There only 2 doses are required. Okay. So it was found that if WHO did a study that if only one dose is given, then the immunity is comparable to the one girls who are taking 2 doses. That is why last time this question come 1 or 2. It is better if one takes 2 doses, but if even the girls forget to take the second dose, the both the type girls who have taken 1 dose and who have taken 2 dose, their immunity is comparable. So answer is 1 or 2. These are the recent WHO SAGE guidelines. Okay. And if the vaccination is given after 14 years, up till 45 years, then 3 doses are required at 0, 1 and 6 month. 0 dose, then at first month, then at the 6th month. Now this is a question. True about vaccination is all except that after vaccination one does not require further pap smear, can be taken with other live viral vaccines. Bivalent is less efficient than quadrivalent, administered on 0, 2 and 6 month. Okay, so the answer to this question is this: does not require. As you have seen that even if we give the patient Gardasil 9, then we have protection only against 9 serotypes. What about other serotypes? Right? What about other serotypes? There is no protection against other serotypes. So other serotypes, they can cause cancer, CA cervix. So one has to undergo pap smear. Even if the one is vaccinated, no, Isra, it is not D, it is A. Okay, listen carefully. Even if the girl is vaccinated, the female is vaccinated from all the 9 serotypes, still there are 100 of serotypes. So pap smear is must for every girl who has taken vaccine or who has not taken vaccine. Okay. So this is right, can be taken with live viral vaccine. Bivalent is less efficient than quadrivalent. Of course, bivalent is less efficient. Yes, I know that here 2 is written, but at some times in the doses comes like 016, sometimes it comes like 026. So the most wrong answer is the A1. Answer is A. Okay. So let us study transformation zone. The zone, okay. Now here I would like to tell you about the squamo-columnar junction. Okay, this is the endocervix and this is the actocervix. This is the uterus, right? This is the endocervix. This is the, if we draw it in the horizontal section, the one which is visible, this all is the actocervix. right? Right? And the one which is not visible in the horizontal section, this tube which is inside, is endocervix, right? When puberty comes, then what happens? Due to the effect of estrogen, the the endocervix pouts out means comes out. Okay, on puberty, actos this is endocervix. Okay, on puberty, the endocervix pouts out. The endocervix comes out under the influence of estrogen. In puberty, a new hormone comes in the female body, estrogen. So the ectocervix comes out. Suppose that this is the endocervix which has come out. Okay, which has pouted out under the effect of estrogen. Okay, now you tell me, what is the epithelium of ectocervix? The epithelium of ectocervix is squamous epithelium, right? This ectocervix is lined by squamous epithelium, and this endocervix is lined by columnar epithelium, right? Isn't it? Now when this endocervix will come out, this endocervix, this blue one is endocervix. Now when this endocervix will come out, this endocervix epithelium will undergo metaplasia, and it will also become squamous. Initially it was columnar, but when it has came out, now this will become, this will again now become, yes, now we will color it with another color. Yes, so now this whole epithelium has become the squamous epithelium, because it has pouted out, it has changed, the epithelium has undergone metaplasia, right? So the old squamocolumnar junction is here. This is the old squamocolumnar junction, right? And this is the new squamocolumnar junction, right? This is the new squamocolumnar junction. The area between the old squamocolumnar junction and new squamocolumnar junction is known as transformation zone, and it contains the metaplastic epithelium. Because this transformation zone contains the metaplastic epithelium, when during the intercourse from the male partner, the HPV lodges here, then at this metaplasia zone, then this HPV causes CA transformation. Okay, so basically, what is transformation zone? The endocervix which has come out and changed its epithelium from columnar to squamous, has undergone metaplasia. Now when this zone gets infected with HPV from the male partner during the intercourse, then that zone, transformation zone, is responsible the site of CA cervix. Okay, so this is the question, what is transformation zone? Each and every line of CA cervix is very important. It is a site where CIN arises, yes. So if it is asked to you, CIN arises where? It suppose the question comes in the exam. CIN arises where? Squamocolumnar junction or transformation zone? So your answer should be transformation zone. Okay? So your answer should be transformation zone. Right? You will not write at squamocolumnar junction. So transformation zone is a site where the CIN arises or HPV causes dysplasia. Transformation zone is a dynamic zone. Transformation zone is a dynamic zone where metaplasia has already occurred. That is why when HPV infects it, very easily dysplasia occur and neoplasia is formed. Then transformation zone, it is formed when columnar epithelium of endocervix pouts out due to estrogen and then is covered by the squamous epithelium. So all of it is correct, right? Now let's discuss the screening. So all of you know that HPV screening is must and it is done by pap smear. HPV screening is must and it is done by pap smear. Okay. So tell me which one of the following is correct about CA cervix screening guideline as per WHO. PAP is repeated early. Is PAP repeated early? Tell me. Yearly. Is pap smear repeated early? Yearly? And it is done by pap smear. Okay. ISRA transformation zone is present in each and every female. Every female who undergoes puberty will have transformation zone. Okay? Okay, Isra? Okay. Which statement is not true about CA cervix guideline? So this first statement is not true. This is false. Okay? The HPV DNA and pap smear, they are not repeated yearly. The new guideline says that they have to be done every 3 yearly. Okay, they have to be done every 3 yearly. Pap smear is repeated less frequently if it is negative. If the pap smear report is coming negative, then it is repeated less frequently. Okay, and visual inspection of acetic acid via it is more reliable in old age as transformation zone is more exposed and clear. So as the female age progresses, what is the difference between squamocolumnar and transformation zone? So you are telling that what is the difference between squamocolumnar junction? Squamocolumnar junction is just a border. If this is squamous epithelium and this is columnar epithelium, it is just the border. This is this border squamocolumnar junction. This is the border, right? And this whole area where the metaplasia has occurred, that whole area where initially it was a columnar epithelium and then now there is squamous epithelium, that is transformation zone. Okay. Now pap smear, now as the female progresses, becomes old, more and more old, more and more endocervix pouts out under the effect of estrogen. So the transformation zone becomes more exposed and clear. Okay. Is it clear to you, Isra? Is your problem clear? The border is known as cramo-columnar junction. The whole area which has undergone metaplasia is the transformation zone. The metaplasia area is transformation zone. Okay. Now let us see in whom we do the pap smear. As I already told you that HPV virus causes CA cervix. So the once the female sexual activity starts, there is a fear that the female can get the HPV infection. Okay. So in whom we will, on an average in India, the sexual activity of females starts around 21 years. Okay. So 21 to 65 years lady, every 3 yearly pap smear is done. From the age 21 to 65 years, ladies, females, every 3 yearly it is done. Okay. Once the female comes in the age 29 years, then the instead of doing it the pap smear every 3 yearly, we can combine the pap smear with HPV DNA assessment and do it every 5 yearly, and we can then do it every 5 yearly. Okay. As HPV DNA assessment is very costly. Okay, it cost few thousands and government is not supplying it free of cost. So if sorry, if a female is not capable of paying it, okay, if a female is not capable of paying it, then it then the female should go for pap smear alone every 3 years. Okay, then a female should undergo pap smear examination every 3 years. Okay. Now, what are the steps in which the pap smear is taken? How we take the pap smear? Okay. Again, it is very important. And first of all, what we will do, we will insert the vaginal wall retractor. In the vagina, the first step is we will insert the vaginal wall retractor. Then we will scrap the transformation zone. Okay, because transformation zone is the zone which is most prone to CA cervix. And then after taking those cells by air spatula, scraping it, then we will put those cells on the slide. Okay, that is what we make the pap smear. And then we will fix the slide immediately with 95% ethanol. So this fixative is asked in exam. What is the fixative? It is 95% ethanol. Okay. And then we will send the slide to the pathologist. Okay. Then we will send the slide to the pathologist. Have you got it? Have you got it? Then you will send the slide. Then we will send the slide to the pathologist. Okay. So, it is asked with which instrument you make the slide. We make it with air spatula. Okay. Now, what is this instrument? Can anyone tell us what is this jar? What is the name of this jar? This jar name is Coplin's jar. Okay. This jar name is Coplin's jar. So, first what we would do, we would prepare the slide, fix it with ethanol, and then we will send it to pathologist. Sometimes it is found that when we transport that slide, as the slide is made up of glass, it used to get break. Okay, so then this Coplin jar was invented. Okay, we don't fix the slide. This jar itself contains the fixative, and it has the areas in which we can carry 5 6 slides. Is that okay? So this is highly expected question. Coplin's jar, image based question. Coplin's jar, it is a jar in which we transport the pap smear slide. It already contains the fixative 95% ethanol. Okay. Then this is the air spatula. This is the air spatula. Okay. Then we can also take the cervical epithelial cells with the help of broom and with the help of cytobrush. Okay, there we put all the cervical epithelial cell in a bottle. Okay, the liquid base cytology bottle, that is known as liquid base cytology bottle. Okay, so if they give you broom and brush, so it is very easy to take that cervical epithelial cell, and there is no need to make slide if we adopt this method of liquid based cytology bottle. Okay, so now when we have taken the pap smear, now we will get the report of the pathologist. Okay, now we will get the report of the pathologist ki how to read that report, right? So either it is a dysplasia classification or it is the Bethesda classification. Okay, either it is the dysplasia classification or Bethesda classification. Okay, in the Bethesda classification, there is a word escus. The full form of it is eight atypical squamous cells of undetermined significance. Undetermined means pathologist was not able to decide what it was. Undetermined significance. Okay, in that case we have to repeat the pap smear after 6 months, right? We have to repeat the pap smear after 6 months. Got it? Got it? Got it? Right? So one thing is this, then second is that there is CIN1. What is CIN1? CIN1 is in the dysplasia classification, and same is in of CIN1 means LSIL, low squamous intraepithelial lesion. Okay, they both are one and the same thing. If one third of the cell, if one third of this epithelium, if one third of the epithelium which the pathologists were seeing under the microscope, if one third of the epithelium is having dysplasia, then we will say it's CIN1. Okay, I'm not speaking neoplasia. Till now, it is not a cancer. I'm just talking about dysplasia. Dysplasia is a pre-malignant stage. Okay, if such a report comes to us, we have taken the pap smear and report comes out to be CIN1 or LISIL1. So, or LISI, low squamous intraepithelial lesion. Then we have to repeat the pap smear after 6 months, and we have to do the HPV DNA assessment, human papilloma virus DNA assessment. Okay, if on the pap smear report it comes out to be CIN2, 3 or CIS. CIN2 means CIN2 means that from one third to two third of the epithelium is involved. Okay, one third to two third. And CIN3 means that more than two third is involved. More than two third is involved. ठीक है? If whole the epithelium is involved, then it is known as CIS, cancer in situ. Okay, in all of the cases, this CIN2, CIN3 and CIS, these in total, they are called as HSIL, high squamous intraepithelial lesion. In these cases, we have to take the biopsy. Okay, we have to take the biopsy because there are high chances. So we have to confirm. Pap smear is a screening test, so we have to confirm it. Okay, now if the dysplasia has invaded the basement membrane, this is the basement membrane, right? This is the basement membrane, these lower cells. If the dysplasia is also present in the basement membrane here, then it is known as invasive cancer. Okay, then it is known as invasive cancer, and there also the treatment is colposcopy biopsy. Okay, so again I will tell you, if the report comes of ASCUS or CIN1, then we have to repeat the pap smear after 6 months. If the report comes HISIL, high squamous intraepithelial lesion, or CIN2, 3, CIS or invasive cancer, okay, then we have to confirm our pap smear report by the confirmative diagnostic test colposcopy biopsy. Okay, so this is a most controversial question which has been asked. Most cost effective screening of CA cervix. The most cost effective screening of CA cervix is via. Okay, here I would like to tell you something, that I am the head of the CAI. I was the head, okay, 1 year back, and I have given a lot of training to nurses, because visual inspection of acetic acid is very, very cheap. It is done by nurses. What we do here, we apply the acetic acid and we see that whether there is any white area or not. Okay, so this VIA is a cost effective, no doubt. What we do, we apply on the cervix acetic acid, and thus we see that if there is any malignant lesion or pre-malignant lesion, then it will very soon it will turn white. Then we will do the confirmative or biopsy report. Okay, other screening methods which can be used is VILI, visual inspection of lobules iodine. But since it is not so common, so we don't do it. We only do pap smear. Pap smear is done by doctors. First of all, a gynecologist is required to take the pap smear. Then pathologist is required to do the reporting. Microscope is required. And in the via visual inspection of acetic acid, we only require a staff nurse and the acetic acid. So of course, via is the cost effective method. Okay, so let's start it. Now, till now we have studied the screening of CA cervix. Okay, now we will study the how the cancer presents. Okay, So here we will study all the three cancers in together, so that you have a very uh, quick understanding. Okay. So first of all, tell me how CA cervix patient will present to you. Suppose you are a doctor, you are sitting in the OPD, write down in the chat box how CA cervix patient, suppose a CA cervix patient come to you. So how, with what complaints the patient will come to you? Cancer cervix is nothing but a growth of the cervix, isn't it? Cancer cervix is nothing but a growth on cervix. So when that growth will rub out of friction, there will be bleeding. There will be bleeding. Agree or not? Okay. So the patient will come with complaints of irregular bleeding. Irregular bleeding. Okay. And during the intercourse also, that growth can bleed out of friction. So patient comes with, yes, patient comes with, yes, Dr. Sumit, you are right. Patient comes with irregular bleeding or post-coital bleeding. Okay, post-coital bleeding, right? And what we will see on examination, on examination we will see that there is a growth on the cervix, right? There is a growth on the cervix. Have you got it? So how the CA cervix patient? So you, all of you know that we are doing lot of screenings in CA cervix, because CA cervix has a latent and phase of, has a latent time of 15 years. From pre-malignant stage to malignant stage, it takes 15-16 years. Okay. How much time it takes from pre-malignant to malignant? It takes 15-16 years. So by screening we can diagnose it. So sexual activity of the female starts at 21 years. Supposing that in and the 21 itself, that female has got the HPV malignancy, HPV malignant type, HPV high risk type, then of course that female will get the cancer at 35 years. That pre-malignant then will become malignancy in 15 years. So the patient of CA cervix is around 35 years or in the old age. Okay, so there are two age streams of the patient, 35 years and 65 years. Okay, when body immunity decreases. Now, CA endometrium. CA endometrium occurs in a 55 years obese lady, because in a obese person there is lot of cholesterol. The increased cholesterol leads to increased estrogen. Increased estrogen leads to increased endometrial proliferation. Okay, got it? You, all of you know now, estrogen is, what is the estrogen substrate? Androstenedione ion. Androstenedione ion. Androstenedione ion is made from cholesterol. Okay. So how will the patient of CA endometrium present to us? CA endometrium is the overgrowth of endometrium, over proliferation of the endometrium. So patient will present with menometorrhagia. Okay, lot of, okay, lot of bleeding. Bleeding cycles will be 6 days, 8 days, like this. Menometorrhagia. Okay, what is menometorrhagia? Irregular spotting is also present, plus the the bleeding phase of the menstrual cycle is long, 6 days, 8 days. So this is the most common complaint, right? The another is prolonged cycle. Now, if that lady has undergone menopause, then C endometrium comes. Then the patient can present to us with post-menopausal bleeding. Okay. Once again, here I would like to remind you, these are one of the very confusing questions students keep on asking to me again and again. Most common cause of post-menopausal bleeding. All of you who are watching, please write in the chat box. Most common cause of post-menopausal bleeding. Most common cause of post-coital bleeding is in the chat box. Write down. Okay. And second most common cause of post-menopausal bleeding. Okay, write down here in the chat box. Be active. Now, the third cancer is tumor ovary. Okay, जो जो ओवरी का ट्यूमर होता है, आई एम यूजिंग द वर्ड ट्यूमर ओवरी, आई एम नॉट यूजिंग द वर्ड कैंसर ओवरी. Why? Because till the last, after operation, till operation we don't know. We will see here. Till operation we don't know what is the cancer, whether that cancer is benign or malignant. Okay, we don't know whether in the case of CA cervix we do biopsy at the first step. In the CA endometrium, we do. Sumit Yadav, Dr. Sumit, why you write here endometriosis? Why you have written endometriosis? Most common cause, I told all of you to write down what is the most common cause of post-menopausal bleeding and post-coital bleeding. Okay, so here I would like to tell you that the ovary tumor, in the ovary tumor, biopsy is at the last. Okay, biopsy is done at the last. So then only we will say CA ovary, whereas in CA ovary, till then we will keep on saying tumor ovary, tumor ovary. So there are two ages in which CA ovary occur. They are 55 years or 55 year and 25 year. Okay, 55 year post-menopausal age and 25 year. Okay, here I would like to tell you, yes, Dr. Sumit, you are right, CA cervix. Okay, here I would like to tell you this ovary tumor is so dangerous that young female of the age of 25 years, I have lost one of my friend. She had a complaint of pain abdomen and she expired after 2 days because of CA ovary. Okay, so mainly the cancers of ovary or tumors of ovary occur at 55 years, but you will study soon that they do occur at 25-26 years also. Okay, now how the CA ovary cancer present? CA ovary cancer present, it is an ovarian mass, right? It is an ovarian mass, and that mass usually contains cyst, right? It is usually cystic. It is usually cystic. Okay, and usually it is cystic. So the patient present to us, ovarian tumor patient present to us with pain abdomen, when we will do PA, we will find a mass, PA or PV, we will find a mass, and that mass will be cystic, and then we will send that patient for the ultrasound. Okay, then we will send that patient for the ultrasound, okay, to confirm our finding. So in total, CA cervix growth present as irregular bleeding, postcoital bleeding, and on examination the cervix is unhealthy and or there is a cervical growth. Whereas CA endometrium patient is a menopausal patient, 55 years old patient, and it present with menomatorrhagia, proliferated endometrium bleeds, prolonged cycles, or postmenopausal bleeding. Okay, whereas ovarian tumor patient present to us with pain abdomen or a large adnexal mass which is usually cystic. Okay, please take this question. Please write down the answer of this question. The lady has presented to us with postmenopausal bleeding. Okay, lady has presented to us with postmenopausal bleeding. Postmenopausal bleeding, the most common cause of postmenopausal bleeding in India is CA cervix. So here the lady is presenting to us with symptoms. Okay, the lady is presenting to us with symptoms. So here we will do colposcopy. Okay, here we will do colposcopy. Got it? The first step, what we do practically, we do both colposcopy. Isra, we will not do visual inspection of acetic acid. Visual inspection of acetic acid is done by nurses. Okay, the answer should be pap smear or colposcopy. Okay, answer should be pap smear or colposcopy. Please don't write via. Okay, we will not do via in any case. Okay, because postmenopausal bleeding is a symptom. When a symptom is there, then we will do the confirmative test. Okay, pap smear is done, a screening test is done when there is no symptom. When there is no symptom. So here we will do colposcopy. Is it clear? Isra, is it clear to you? Dr. Sumit, is it clear? Please attempt this question. These all are PYQs and they are expected in your exam. Please write down in the chat box answer. Yes. Yes, Dr. Sumit, it is right. Pap smear It's right, is right. 35 years old lady with postcoital bleeding. Now, postcoital bleeding is a symptom. Ideally, this should also done colposcopy. But since colposcopy is not an option, so we are going with the screening method. Okay? Sometimes old question do come in FMG. That's why I have taken. Okay? Now write down answer of this. Take this question, please. A patient came to you with history of postmenopausal bleeding. On examination, cervix is hypertrophy, erosion is there. What is your next step? Cervix is unhealthy. What is your next step? Now you are able to see the lesion. Cervix is unhealthy. No, answer is 4 quad biopsy. The ideal answer should be called, it should be punch biopsy. Okay? Punch biopsy. But since it is not there, so we will write down 4 quad biopsy. Okay? Because we are able to see the lesion. Cervix is hypertrophy. Cervix is eroded. Patient is having symptoms. Okay? Okay? Now let us go and rule out. Now we have studied ki a patient came to you, of the CA cervix patient came to you with irregular bleeding, right? And endometrium cancer patient came to you with manometorrhagia, and the tumor ovary patient come to you with a abdominal mass, cystic abdominal tubo-ovarian mass. Now the question is that how you will, now what you will do as a first year resident or as an intern, you will rule out the risk factors. Okay, the what are the risk factor of CA cervix? As we have already studied, the CA cervix is caused by HPV, right? And HPV is transmitted, or telegram. Yeah, you can send. You can send the your answers on Telegram. It has been opened. You can send the answers on Telegram. Okay. So we were studying that what are the risk factors for HPV, right? What are the risk factors for HPV? Okay. So So the risk factors for HPV, when will be the HPV transmitted? Okay, so HPV is only transmitted from male to female during the intercourse. HPV is a STD. Okay, HPV is a STD. Got it? So it is only transmitted from male. So more the female will have the sexual activity, more will the HPV transmitted. So how you will ask the female will that you have you are sexually active or not? So you can ask it by the fact, by asking the female that when is your first, at what age you have the first child. Okay, at what age you have the first child. Got it? At what age you have the first child. Got it? So more will be the sexual activity, more early will be the first child. Got it? So if the child bearing age is before 18, it is again a risk factor. Then multiparity, more is this, more the female had the sex, more the child the female will bear. Right? More the child the female will have. So again it is a risk factor. Multiple sexual partner. Okay, multiple sexual partner. More the partner the female will change, more chances of HPV transmission. It is possible that the female will not have the HPV transmitted from one male partner, but it can have from another, right? So woman with STD. So it is possible that the woman who has a sexual transmitted diseases, that woman has the chances of HPV also, right? And again, low socioeconomic status. It is considered that the people who have a low socioeconomic status, they have only one pleasure, right? Then smoking, alcohol, and IV drug abuse, these all increase the chances. So these all are the risk factors. Are you clear with it? Are you clear with it? In the CS cervix risk factor, mainly you have to ask about the sexual activity of that female. If a female with unhealthy cervix or irregular bleeding comes to you and you get unhealthy cervix, then you are going to rule out the CA cervix risk factor. Okay? In a patient of CA endometrium, what all risk factors you will rule out? This risk factor of CA endometrium is very, very important. Very, very important. Question comes only on CA endometrium risk factor. Okay? Questions come only on CA endometrium risk factor. Okay? Okay. So now I already told you, more is the estrogen, more will the endometrium proliferate. Right? More is the estrogen, more will the endometrium proliferate. Okay? More is the estrogen, more is the endometrium proliferate. So when will be the more estrogen? In high estrogenic stage, when there will be early menarche, right? Early menarche will start early, then early estrogen will come and proliferate, right? Early menarche and late menopause. Okay, early menarche and late menopause. More late will be the menopause come, more late will be the more late will be the proliferation stop, right? Next is nulliparous. Why nulliparous? Once the lady becomes pregnant, endometrium proliferation stops. So for 9 months the endometrium does not proliferate. So I already told you, more is the endometrium proliferation, more are the chances of CA endometrium. So moreover, when a lady gets pregnant, the periods also stops during the lactation period, lactational amenorrhea. So one pregnancy means 1.5 year of amenorrhea. So, and 1.5 year of no proliferation, endometrium proliferation. So nulliparity is a risk. The lady who has not become parous, has not delivered, will don't have this stoppage of endometrial proliferation. Okay. Now, why obesity, diabetes, and hypertension? Answer to this is, more is the patient obese, diabetic, and hypertensive, more cholesterol the patient has, more androstenedione is formed from the cholesterol, and more is the, come on, give me the answer. More is the estrogen form. So more is the endometrium proliferates. Okay, have you got it? Okay, now these two factors which I will be discussing now, these are quite commonly asked: tamoxifen and HRT. Tamoxifen and HRT are very favorite of examiners. Okay, tamoxifen is a drug which is given in breast cancer, It is anti-estrogenic on breast, but it is estrogenic on endometrium. Okay, I have one or two my aunts, they are having CA breast. As you all know, CA breast is a very common cancer in females, right? Most common cancer. So what they do, they take tamoxifen and they get prone to CA endometrium. So they come to me for regular visit कि CA endometrium हो गया कि नहीं हो गया, नहीं इस बार नहीं हुआ. Okay, then come to me next visit. So they knew that they will get CA endometrium once they are taking the medication of CA breast, because tamoxifen is estrogenic on endometrium. This has been asked in FMG June 22. A patient who was taking tamoxifen has bleeding. What is the diagnosis? Diagnosis is vaginal bleeding. Diagnosis is endometrial cancer. Again, a patient who is taking HRT. HRT is nothing but estrogen. Okay. Out of this, the most important are these two risk factors: tamoxifen and HRT. Okay. The other helps to rule out. Right. Now, let us talk about the tumors which have increased estrogen. Granulosa cell tumor. You all know granulosa cell, they synthesize estrogen. If granulosa cell tumor is there, then there will be the factory of estrogen, right? And PCOS, in PCOS, there is no ovulation. So hyperproliferation of endometrium occurs. So PCOS and granulosa cell tumor both are at the, makes the patient prone to CA endometrium. Okay. Is it okay? Next is tumor ovary. In the tumor ovary, the most important tumor ovary, the most important risk factor is BRCA mutation. BRCA mutation. Okay, if this mutation is present in hereditary, in the heredity, present in any of the first degree, second degree relation, because you all know if BRCA mutation is there, then the patient can have ovary or CA breast. Okay, then there are 50% chances that the patient will have CA ovary or CA breast. Most important risk factor is CA for the tumor ovary or CA ovary is BRCA mutation. Never underestimate, because in PCOS ovulation does not occur, Isra. Because in PCOS, Isra has asked why PCOS is risk for endometrial cancer. Okay, why PCOS is risk for endometrial cancer? In PCOS, ovulation does not occur. Menstrual cycle does not go into the ovulation phase, luteal phase. Estrogen phase, proliferative phase prolongs. Proliferative phase prolongs. There is hyperproliferation. Okay, right? That's why. I hope you understand, Isra. I hope you understand. Okay, so the answer to the question is because of the prolonged proliferative phase, right? In tumor ovary, what happens? BRCA mutation is the most important risk factor, and this mutation is transferred hereditary. Okay, is transferred hereditary. If the mother or sister or any first degree relative, second degree relative is having the CA ovary or CA breast and also BRCA mutation positive, then 50% chances are there that that female will have the cancer. Okay, now let's discuss about the other factors which cause tumor ovary. Now here we are talking only about epithelial ovarian cancers. Okay, epithelial ovarian cancers. Okay, now what are the factors which causes epithelial ovarian cancer? What is the function of ovary? Epithelium. What is the function of the epithelium? Its function is only one function, that it ruptures during the ovulation. So more the lady undergoes ovulation, more are the chances of epithelial ovarian cancer. Okay, okay, is it clear? More the lady undergoes ovulation. So when the lady will go undergo more ovulation, if the lady is having early menarche and late menopause, right? If the lady is nulliparous, because in pregnancy ovulation also stops, right? The another important factor is infertility treatment. What is infertility treatment? I already told you in infertility class, when we take the patient for IVF or we give infertility treatment, we undergo the patient to go ovulation induction, and there many ovas are formed. So all that ovas ovulate also. So more is ovulation, more is the risk. Okay, more is the ovulation, more is the risk. So once again I am telling you, if a patient of CA cervix comes to you, a patient comes to you with irregular bleeding and you get a clear cut growth on the cervix, then you will rule out it's the female sexual activity. Okay, And if you will if you will if you get a patient of menometorrhagia, 55 years old female, you will suspect CA endometrium, right? Then you will rule out proliferation, endometrium proliferation factors. Okay? And if you get a patient of abdominal mass, right? Then you will rule out BRCA mutation and the ovulation factors. Okay? Clear? Now, please attempt this question. This is very important. Please take this question. This is the last year PYQ. Yes, it is endometrial cancer. Okay? You can type in Telegram. Okay. The next question is, please take this question, type the answer. Be fast. So the answer is multigravida. Very good. So this is another question, and answer to this is endometrial cancer risk is all a risk factor except smoking. Smoking is not the risk factor, smoking prevents. Okay, so let's go to the next. This is the question. 37 years old lady on oral contraceptive pills. Her mother had breast cancer at 55, sister had ovarian cancer at 40. It means it is a high chance of BRCA mutation. So now this lady has come to you. What will be your next step? Okay, so in this we will do the BRCA mutation check, genetic testing and BRCA testing. Okay, genetic testing and BRCA testing. All are risk factor for the development of ovarian cancer except answer is use of oral contraceptive pill. We have already studied that ovarian cancer is prevented by oral contraceptive pill. Okay, now let's do the confirmatory test. Okay, so what are the confirmatory tests? Here I would like to tell you that the confirmatory test for the CA cervix is, if you are able to see the lesion, then we will do the punch biopsy from that lesion. If on the cervix you have seen the lesion on the cervix, then you will do the punch biopsy. Okay, if you are not able to see the lesion, then you will help yourself to see the lesion by colposcopy. Okay, colposcopy is nothing but camera. Okay, colposcopy is nothing but camera. Then we will see the lesion with the help of colposcopy. So we have to do the biopsy. Confirmatory test is no doubt the biopsy. Okay, Confirmatory test is no doubt the biopsy, but if you are able to see the lesion, then the test is punch biopsy. But if you are not able to see the lesion, then you will see the lesion on the cervix with the help of colposcope, that we will discuss next. Okay, so see, this is the colposcopic guided. What do you mean by colposcopic guided punch biopsy? When a patient come to you with irregular bleeding or postcoital bleeding or postmenopausal bleeding, then you suspected CA cervix, you rule out the risk factor. Patient told you, yes, I am a prostitute, I have multiple sexual partner. So you are very suspicious that this patient is having CA cervix. Okay. Now you look at the patient's cervix, but there is no lesion on cervix. The patient is symptomatic, but there is no lesion on cervix. Now you cannot do pap smear because pap smear is a screening test. Okay. Now you have to confirmative test, right? So confirmative test is you have to see the cervix under colposcope. Colposcope is nothing but magnification lens. Okay, so you see the cervix under magnification. Of course, you will see something. You will see some ulcers or like that. Okay, so on magnification, you can see a ulcerative growth. There are 4 steps in colposcopy. First step is to see the cervix under magnification. Okay, to see the cervix under magnification. Next is Schiller iodine. You will apply on the cervix Schiller iodine. Okay, Schiller iodine. What is the color of Schiller iodine? This, like this, it is of this brown color. Okay, whole cervix will change brown color when you will apply Schiller iodine on it. But the cell which are cancerous, they will not turn brown. They will not turn brown because glucose in the cell make the cervix brown. The cells which are cancerous, they are rapidly dividing. They don't have glucose. They have utilized all of their glucose. They have utilized all of their glucose. So the cancerous cells will not be brown. They will be mustard yellow. सरसों के खेत जैसे. They will be mustard yellow like this. Are you able to see? The cancerous areas on the cervix will be mustard yellow because the rapidly dividing cells, they utilize all their glucose. Okay, so the cancerous area on the cervix will be mustard yellow. They will not be brown on application of Schiller iodine. Okay, then next thing which you will do is you will apply acetic acid. Acetic acid is transparent color liquid. Okay, the cervix, suppose this is cervix. The cervix which is the cervix which is cancerous, the cervix which is cancerous has high protein because DNA transformation is occurring there. DNA, again and again, rapidly dividing cells, they have more protein, so they will become white. On application of acetic acid, they will become white. Okay, if rapidly dividing cancerous cells are present, they will become white. Okay, right? Because they have cancerous cells, they have more DNA, they have more proteins. Then next is green filter. So what we do in green filter, we and last step is green filter. So we throw green light on cervix. This was a question of last PYQ of FMG. Which color filter we used while doing colposcopy? The answer was green filter, right? What happens in green filter? In green filter, the vessels, it looks white in color. Okay, this can be the next question. And you know that rapidly dividing cells, they they have neovascularization. Every tissue needs its vessels, blood, nutrition, right? So if there is cancer is present, then you will find vessels. Okay, now after performing these four steps of colposcopy, now you come to know that yes, this is the area. For example, if I say that in this area you find neovascularization, right? Then from this area you will take the punch biopsy. Is it clear to you? This colposcopic guided punch biopsy is only taken if on the naked eye you are not able to find the lesion. Okay. In the case of CA endometrium, let's talk about CA endometrium. What is the confirmative test? Please tell me what is the confirmative test in the case of CA endometrium? Endometrial biopsy. Okay, we take the endometrium biopsy and we send it to pathologist. Okay, the biopsy which is very commonly done is the Peple biopsy, because it is a uh, refill like instrument from which we take the endometrium. No anesthesia is required, nothing is required. So we write down with the name of that is office office. Hysteroscopic guided biopsy is 100% 100% confirmative method, but most commonly done is office Peple biopsy. Okay, okay. Hysteroscopic biopsy is the best test, but that requires general anesthesia. So we have to call the patient next time. In India, patients are not aware. It can be there that the patient don't come up next morning, right? So we can lose the patient. So that is why office biopsy is done. For this, no anesthesia is required. The biopsy instrument is just like our pen refill. Okay. For the ovarian tumor, we undergo ultrasound and we order tumor markers. Okay, we order tumor markers. I already told you that in ovarian cancers, ovarian tumor, the biopsy is done at last. Okay, biopsy is done at last. Let us see which all tumor markers are for what all cells. Okay, so first of all, there are three type of ovarian tumors. All of you will please listen carefully. It is very important. Lot of questions are coming from this slide. Ovarian tumor types and tumor markers. Okay, please listen carefully. There are three types of ovarian tumor. Epithelium. Okay, if this is ovary, this outer one is epithelium. If the tumor arises from epithelium, then it is epithelial ovarian tumor. Okay, if the tumor arises from germ cell, now ovary contains follicles. Okay, and follicle has germ cell or ovum in it, right? If that germ cell becomes tumorous, then it is known as germ cell tumor. Okay, and if the follicles become tumorous, then it is known as follicular cell tumor. What are the three types of ovarian tumor? Epithelial ovarian tumor, germ cell tumor, and the sex cord or follicular cell tumor. Okay, why follicular cell tumor is known as sex cord tumor? Because follicles synthesize estrogen. Granulosa cells synthesize estrogen. Due to that estrogen, a female is female. Do you remember in Turner syndrome there was no estrogen? So the femininity was lost in the Turner syndrome, right? Okay, so that is why follicle cell tumors are also known as sex cord tumors. Okay, now next is the epithelium ovarian tumor. They are of different type, right? You all know epithelium ruptures during ovulation. Then the follicle ovum comes out and it goes into the fallopian tube, right? Now on that ruptured epithelium, what all growth factors act? That type of tumor will it become. If the fallopian tube growth factors act on that ruptured, then the tumor mass will be serous, right? Because fallopian tube makes serous secretions. Now on that ruptured epithelium, most commonly it is serous ovarian tumor. The ovarian mass which is found in the 55 years female is serous, because most commonly fallopian tube growth factor act. If cervix growth factor acts on that ruptured epithelium, then mucinous tumors are formed. If bladder or tumor markers act, then Brenner's tumor. If endometrium growth factor acts on that, then endometrioid tumor or clear cell. This question has been asked twice. Clear cell is of which type? Clear cell belongs to which type? Right? Clear cell is a epithelial ovarian tumor type. Okay? Clear cell is the epithelial ovarian tumor type. Most common is the serous. Most common tumor out of all this is the epithelial ovarian tumor. Most common tumor out of all these among epithelium is this. In fact, they are 90%. They are 90%. So if they ask out of all the ovarian tumor which are most common, these are the question which they ask. Okay? Here only that question I will ask to you which have been asked twice or thrice. Okay? Which have been asked twice or thrice. So most common among epithelium, germ cell and sex cord is epithelial ovarian tumor, and it is 90% of all the ovarian tumors. So if वो कैसे भी आपको घुमा के बोले किसी भी तरीके से, if they ask you like this, which is the most common benign ovarian tumor, your answer will be epithelial ovarian tumor. which is the most common malignant ovarian tumor? Your answer will be epithelial ovarian tumor. Okay, the tumor marker for the epithelium ovarian tumor is CA125. And among epithelium ovarian tumor, the most common is the serous. Okay, serous, because fallopian tube is lying over the ovary. Is that okay? Now, to understand the germ cell tumor, we have to divide the ovum into three parts. Okay, what does ovum make? Ovum makes, after fertilization with sperm, ovum makes fetus, ovum makes placenta, ovum makes yolk sac. So ovum makes three things, right? What are those three things? Ovum makes fetus. Now, if so, I will label it here that ovum after fertilization make fetus, placenta, and yolk sac. If the part of the ovum that makes fetus that becomes tumorous, then teratoma will be formed, and it is the most common germ cell tumor. Its benign form is also known as dermoid cyst. Already the question has come in the INSET November. Okay, INSET November questions were very basics. Please focus. The most common germ cell tumor is teratoma. Its benign form is known as dermoid cyst, and that is the form which is in which the ovaries we get hair, thyroid gland, all the three germ cell layer. Multiple questions have been asked on teratoma and dermoid cyst. Dermoid cyst contain the three germ cell layer products. Okay, the another tumor is yolk sac tumor. The another name of the yolk sac is endodermal sinus tumor. Okay, endodermal sinus tumor. You all know that yolk sac is a source of nutrition. The tumor marker of the yolk sac is alpha fetoprotein. Alpha fetoprotein, because yolk sac is a source of nutrition, so its tumor marker is protein. Okay, and no, the part of the ovum which makes placenta, if it get tumorous, then it will make HCG, right? HCG. Then its tumor marker for non-gestational trophoblastic neoplasia or choriocarcinoma is HCG. Okay. Now, there is a cell known as primordial germ cell, right? Primordial germ cell. Primordial germ cell, if that primordial germ cell makes the germ cell, if that primordial germ cells become malignant, then it forms dysgerminoma. Dysgerminoma. The tumor marker of the dysgerminoma is LDH. I hope it is clear to you. It is LDH. Okay. Right. So most common tumor of germ cell tumor is dermoid. The most common malignant germ cell tumor. Many times they have asked you. Okay. Most common malignant germ cell tumor. They are not asking you most common malignant ovarian tumor. Answer to most common malignant ovarian tumor is epithelial ovarian tumor or serous ovarian tumor. But the answer to most common malignant germ cell tumor is dysgerminoma. Okay, right? Either they will ask you most common or they will ask you tumor marker. Tumor marker, write down in the chat box what is the tumor marker of Write down in the telegram, tumor marker of yolk sac tumor. It is alpha fetoprotein. What is the tumor marker of non-gestational trophoblastic neoplasia, HCG? What is the tumor marker of dysgerminoma? It is LDH. Because dysgerminoma is not differentiated, it is undifferentiated germ cell, right? It is it is homologous to the seminoma of the testes, right? Okay. The third type of tumor is sex cord tumor or follicular cell tumor. In this, the most common is the granulosa cell tumor. Sex cord cell tumor contains two type of tumor, or granulosa cell tumors and theca cell tumor. You all know granulosa cell makes inhibin and estrogen. So their tumor marker is inhibin B. Okay. So now you will not forget what is the granulosa cell tumor marker. Okay. There is one another tumor of sex cord type is fibroma. The fibrous cell, right? Fibroma. Now, please listen carefully. What happens in fibroma? The fibers of the ovary, they become tumorous. Okay. So, as fiber is a protein, so when more and more fibers will be formed, so body protein will be utilized. So body will go into, that female body will go into hypoproteinemia, and there will be ascites and pleural effusion, and that is known as Meek syndrome. What is Meek syndrome? Meek syndrome means fibroma of ovary plus ascites plus pleural effusion. Okay. Now when we see this patient clinically, we thought that this patient is very sick, because this patient is having ascites, because this patient is having pleural effusion, right? But if we simply remove the tumor, everything cures. Because this tumor is very large, it means that it is benign. More is the tumor large, more are the chances that tumor will be benign. Okay. Because if the tumor would have been malignant, very soon the patient would have died. Small malignancy can make the worst prognosis. Okay. So if the tumor is large, sufficient large to cause ascites, it means that the tumor is benign. So what is Meek syndrome? Meek syndrome means benign fibroma of ovary plus ascites plus pleural effusion. Okay. So now we know. Now we know the confirmatory test reports, how you will confirm the testicular tumor and all those things. Okay. So now we will know, you know that what all has happened. Okay. So now I would like to tell you, okay, how you will interpret the report of the various tests. Okay. Should we continue tomorrow, or you want to end it here only? Should we continue tomorrow, or you want the session to continue? Please tell. Interpretation of reports and treatment is left. Please write in the chat box, would you like to continue tomorrow or now? Continue. Okay, it might be that emergency is waiting for me, that I have to go. At that time, I will close the class. Okay, close the session. Okay, so let us see how we will interpret that reports. In the CA cervix suspicious patient, we have sent the cervix punch biopsy report. Right? We have sent the cervix punch biopsy report. Now, in the suspicious patient, either it can come the pre-malignant lesion or it can come cancer, right? Either it can come the pre-malignant patient or pre-malignant lesion, or it can come cancer. If it has come CIN1, then no worries. Okay, in the case we have taken the punch biopsy report, on the punch biopsy report either it will be written CIN1, CIN2, CIN3. Now this is not a pap smear report, it is punch biopsy report. Okay, so if CIN2 and 3 is written on that report, what is the treatment? Then we will excise that area of the cervix, and excision of that area of the cervix is known as LEEP. LEEP. Okay, LEEP. Okay, LEEP means electrical laser excision of that suspicious area. Okay, if invasive cancer is written on report, it means that the dysplasia has penetrated the basement membrane, right? It means that the dysplasia, if the report says CIN2 or 3, then its treatment is LEEP. Okay, now if the report says invasive cancer, it means that dysplasia has penetrated the basement membrane. Then the treatment is conization. We have to remove the whole cone. And if on the report there is written squamous cell carcinoma, then we will undergo clinical staging. Okay, clinical staging. Once it is confirmed on the report, biopsy report, that yes, this is a cancer, then we have to treat that cancer. What treatment we will give, that will depend on the clinical staging. At what stage? And only one cancer in the gynae is staged clinically, and that is CA cervix. Rest all cancers are undergo surgical staging. We do a surgery and then we perform the yes. Okay, next is the how we will interpret the endometrial biopsy report. Okay, the endometrial biopsy report, if it is written what is the pre-malignant lesion of endometrial proliferation, CA endometrium का pre-malignant lesion क्या होता है? Hyperplasia. Okay, hyperplasia, right? That hyperplasia can be simple, can be complex. That can be with atypia or without atypia, right? That can be with atypia or without atypia. So it is very frequently asked that if it is a simple hyperplasia, if it is simple hyperplasia, if on the report pre-malignant lesion has come, simple hyperplasia, without atypia, what is the risk? Only 1%. What is the risk of CA's endometrium in a patient whose biopsy has The pre-malignant lesion, simple hyperplasia without atypia, it is only 1%. The next pre-malignant lesion can be, next risky pre-malignant lesion can be, yes, complex hyperplasia. Instead of simple, the hyperplasia is complex, but still atypia was not seen by pathologist. Now this time the risk of CA endometrium will be 3% in the future. Till now, it is not CA endometrium. These are the pre-malignant lesions. The risk of complex hyperplasia without atypia is 3%. Okay. Now you tell me what will be the next lesion. Next pre-malignant. Simple hyperplasia with atypia. Okay. Now this time the hyperplasia was simple, but it was with atypia. As atypia is there, now this time the risk is 8%. 8 to 10%. Okay, 8 to 10%. And in case of complex hyperplasia with atypia, the risk of CA endometrium is 30%. These percentages are asked and you have to learn. So the first one case, simple hyperplasia without atypia, risk was 1%. The rest you can learn, 3 into 10 is equals to 30. Okay, if no atypia is there and if there is no atypia, then the treatment is progesterone. If atypia is absent on histopath report, then the answer is the treatment for this pre-malignant lesion is, in the CA cervix, the treatment for the pre-malignant lesion was LEAP. In CA endometrium, the treatment of pre-malignant, yes, you're right, Isra. The treatment of pre-malignant lesion without atypia is progesterone, and the treatment of pre-malignant lesion with atypia is hysterectomy. Because there are high chances, then the treatment is hysterectomy. When atypia is there, then the treatment is hysterectomy. If on the biopsy report and adenocarcinoma is there, adenocarcinoma is written, cancer is there, now this time no pre-malignant lesion, then what treatment we will give, Isra? Then what treatment we will give? Write down in the chat box what treatment we will give. Then we will undergo surgical staging. Now this is a cancer. We will do treatment as per staging. In endometrial cancer, we do surgical staging. Which surgery we do? Hysterectomy with BSO. Okay. Hysterectomy with bilateral salpingo-oophorectomy. Okay. Is it okay? Okay. Now, in the case of patient of ovarian tumor, we have sent tumor marker. Okay. Right? Suppose that the tumor marker AFP, alpha fetoprotein, comes high. So, now we have to take the patient for surgical staging. Right? We will take the patient for surgical staging. And what is the surgery for the ovarian tumor? The surgery for the ovarian tumor is debulking surgery. ISRA, it is hysterectomy with bilateral salpingo-oophorectomy. Patient is a known case of cancer, right? We also want to find its spread. Okay? Okay? Okay. Ovarian tumors, the surgery for the ovarian tumor is debulking surgery. Okay? Debulking surgery. ओके एंड व्हेन वी डीबल्किंग मतलब जहां जहां आपको ट्यूमर दिख रहा है, जहां जहां आपको अल्सरेटिव ग्रोथ दिख रही है, वेयर एवर यू आर सीइंग द ट्यूमर, वेयर एवर यू आर सीइंग द अल्सरेटिव, टेक आउट take out that growth, send that growth to biopsy. In addition to, you take 3 more biopsy. In addition to that ovarian mass, you take 3 more biopsies, and that are ascitic fluid, retroperitoneal lymph node biopsy, and omentum biopsy. The 3 other biopsies which you have to take is ascitic fluid biopsy, retroperitoneal lymph node biopsy, and omentum biopsy. Is it clear? You will take out the tumor, plus you will take out you will take 3 more biopsies. Is it clear to you? There is one emergency waiting for me. Please reply. We will continue the session tomorrow. Okay? If there is any problem, please write in the chat box or in the Telegram group. The rest of the session will be done tomorrow. If there is any query, please write in the chat box or Telegram group. Okay, so we will continue the session tomorrow. It will be at 4:30 to 6:30 approximately. Okay?